share my screen, but it's not currently working. So I'll just go ahead and start with introductions. My name is Jalen Page, and I'll be your moderator for this first half of the session. Our topic is innovations in medical care. We have two great speakers here with us today that offer us a wealth of knowledge. The first speaker we have is Benjamin Greenberg. Ben currently works as the Global Director for Social Sciences. This includes the application of sciences like anthropology, behavioral, economic, and public health. Ben has also worked to build a team of interdisciplinary members across a global network. His work also includes prescription over-the-counter products, as well as consumer packaged goods. Additionally, Ben has worked in 14 plus disease states, working with cystic fibroids, heart failure, diabetes, and cancer. Ben, thank you so much for joining us today. We're excited to talk to you and pick your brain. Let's begin. So over these past 7 months, the pandemic has been affecting everyone's life a great deal, where medical professionals and patients have had to adjust to new standard operating procedures. Now that a lot of things are moving virtual, Ben, please tell us, in your opinion, some of the disadvantages and advantages of in-person and or virtual care.
Yeah, so hi, Jalen and everyone, pleasure to be here today. So as far as the advantages and disadvantages of in-person versus virtual care, speaking as someone who is not a physician themselves, but certainly has done a good amount of research and speaking with that, there's some interesting stuff that we're seeing in terms of trends that happened and how those trends have been impacted by the pandemic. So for example, some doctors' offices, depending on their resources, have actually found this very systemic way of approaching patient care, where a lot of their office staff will be on on call from maybe 2 to 5 o'clock to deal with paperwork and all that type of stuff. And because of the virtual care, they're able to sort of systematically see patients a little bit more. Other doctors' offices have obviously not been able to get as many patients or been able to switch over to virtual care, and so have unfortunately lost a good amount of business and have not been able to provide those patients with care anymore. So it's unfortunately a completely mixed bag in terms of the impacts for each of those different practices. And I think as far as the advantages of the advantages to virtual care, I think that we're seeing some interesting things in terms of how that has created an opportunity and a challenge for the doctor-patient relationship as well. So in speaking with a good number of physicians, we've sort of seen them, their relationships with their patients start to change just based off of the fact that they're no longer actually physically in that doctor's office. This also is important it's also important to think about the type of care, right? So if you're thinking about in-person treatments with regards to rehabilitation, for example, versus in-person care for simple checkups or you have a cold or something like that, I think it's a big difference, right? So there was a huge drop in the number of patients in rehabilitation practices, so OT, PT, and a lot of those practices have been losing patients. They haven't been able to obviously see them. They've been doing more virtual care, but it seems less effective, or the perception is that it's less effective. It's not necessarily the case, but the perception is that it's less effective for virtual care in that regard, versus having a checkup or saying like, I have a fever and I probably have a sinus infection, can you give me an antibiotic? That has certainly been a trend that was already happening before the pandemic. More and more people were sort of doing that via virtual care, and now it's something that happens pretty often. So it's advantageous because it sort of helps to deal with some of that volume that doctors were seeing a lot of patients, but there's a disadvantage for people that really do need the in-person contact for those types of for the type of care that involves more personal touch, like OT and PT.
So that you make a great point about how that personal touch is needed. So how do you think that physical separation from patient care has been affecting treatment overall?
It's also a great question. So there's something that our industry refers to as the doorknob conversation, which is when a doctor is speaking with a patient and the patient's on their way out and they have their hand on the doorknob and they say, oh, one more thing. That's usually the thing they came in for. And in that doorknob conversation, it's been sort of a mixed reaction in terms of whether that's been happening more freely versus whether that's happening less frequently. And the interesting sort of psychological dynamics behind that are when you have, a glass screen or something in between you and someone else, you do feel a little bit more emboldened to say, certain things or do certain things, right? I think we've seen that in just looking at social media, right? Like people will, if they don't have to necessarily put on their camera, if they can sort of hide behind a screen, they're more willing to say pretty much anything. So I think in that regard, there's certainly an additional layer of humanity that's injected into that conversation, right? We were doing a project recently where we saw a doctor who was seeing a patient, and the doctor the doctor's dog started barking in the middle of the virtual appointment. And so they had to obviously deal with that, and they had a nice dialogue around it. So there's this really interesting humanity. But at the same time, physicians in med school are traditionally trained, you need to touch the patient, have this physical contact. And with that regard, I think it's definitely impacted that sort of doctor-patient relationship, because being able to physically, touch the patient and make that connection is a big part of patient care. And there's also something very different about, seeing physical symptoms in person versus, seeing them virtually. So more advanced tracking of different diseases is also really difficult, right? So with testing for something, like we work on a product that is supposed to help with atherosclerotic cardiovascular disease, and tracking LDL-C is really important, but obviously you can't do that without a blood test. So there are at-home care kits that help you to test for it, but they're not super great. And so tracking diseases like that over time is obviously significantly more difficult in terms of that physical separation. So I'd say those are probably some of the biggest things that have impacted patient care in general with regards to physical separation.
And, I understand when you're talking about, it being that big part of separation, and the big part about tracking disease is not as easy anymore. But I know there has to be some healthcare out there that's going to offer a full replacement of in-person, versus virtual over the coming years. What different types of healthcare do you think will be replaced with virtual over the coming years?
So that's a great question. With regards to what will be replaced, I think that sort of goes back to some of the stuff I was saying about it depends on the disease state, right? So triage of certain conditions, I think, will be significantly altered. So if I just have a cold, or I have a mild fever, or my nose is runny, or whatever, there's going to be some significant changes in that regard. So there's a startup company called 98.6 who has essentially worked with a team of physicians to essentially train an algorithm to diagnose the very simple diseases like the cold, like flu, like sinus infection, things like that. And so that is going to take a significant burden off of physicians for sure, because those are sort of the small, easy to, I'm not a doctor, so when I say easy to diagnose, take that with a grain of salt, but the easy to diagnose conditions, that'll certainly take that triage element out of it. I think as far as other things that will sort of replace or impact things that will replace care in the future virtually would be digital therapeutics. So digital therapeutics are something that can be utilized at home in a lot of cases. It sort of depends on what that digital therapeutic sort of does in particular, right? So there was a video game developed that is a digital therapeutic for kids with ADHD. There are digital therapeutics being developed around music therapy. There are digital therapeutics that are being developed for seizure. It's kind of an incredible innovation, and a lot of the really cool, or I think a really cool part of that is that some of it can just be delivered in your home rather than having to necessarily go somewhere. So I think digital therapeutics for sure are going to be a part of it, and then companies like 98.6 who are trying to sort of augment and maybe sort of lessen the burden of triage on physicians will be pretty important.
Thank you so much for that. I think we have time for one more question. So every day there are constant innovations and re-imaging in the medical field. Please give us your perspective on what a doctor's visit in the future would look like.
So it's a great question. When you look at companies like Patients Like Me, and you look at companies like Forward and Parsley Health, when you think about the combination of all of those different things, proteomics is going to be a critical factor in the future of care. Genetics is going to be a critical factor in the future of care. The introduction of holistic medicine and sort of this augmented element of care where you can pay a company like Forward or Parsley a premium price where they will spend an hour with you. Their physicians will spend a full hour talking to you about everything under the sun, doing full body scans, really trying to give you an understanding of your health status and have a significant focus on preventative care. So the future doctor's appointment, I think, will involve a combination of those two elements where you'll be able to understand on a very one-to-one basis, based off of proteomics and genetics, the unmet needs of that particular patient, some of the things that will make their lives better or worse from a quality of life perspective. So I mean, like, if I do take fish oil every day and I have the genetics that I have and the proteins that I have, is that actually going to help me? So being able to provide that type of care, and a shift that will be likely to be about prevention and holistic care, I think, will probably be involved in the doctor's visit of the future.
Okay, thank you so much, Ben. I really appreciate you speaking with us today. I actually think we have time for just one more question. This is my favorite one of all. So just one more, please. So what technologies, processes, and standards of other innovations are needed to make virtual healthcare just as effective as in person?
So I have a lot of thoughts on this one, but I'm gonna be brief and just say that equitable access to these types of innovations is going to be critically important, right? When the example I gave about PT and OT, for example, or just general rehabilitation, when you look at rural hospitals, based off of what's been happening with COVID, their loans are starting to come due. So with the trouble that those rural hospitals are in, and the fact that the closing of rural hospitals has been correlated with a significant increase in patient mortality and morbidity in those areas, digital therapeutics and equitable access to all of these types of technologies in the future is going to be paramount to try and make sure that these are effective and they're making the most impact. And I think that the issue becomes some infrastructure related things. For example, broadband access, if you're going to engage in telehealth, right? That needs to be that needs to be built out. And even things just as simple as digital literacy, making sure that people actually understand how to use these things in certain areas and certain communities. And then a focus on health literacy, right? So do I understand and am I able to act on the information that I'm being given? Do I understand how to use all of this medical, mumbo jumbo, basically, and how it fits into my life? And do I know what actions I need to take next? I think that those are all important things that need to be remedied, and those can be remedied through everything from local and state governments sort of partnering with health systems of care to make sure that they're able to subsidize broadband access so that people can utilize certain services, all the way through to just simply doing education campaigns to make sure people know exactly what they're getting themselves into, can understand and interpret all of the health information that's being thrown at them, and just simply know how to use some of the stuff and how it works with your insurance, because there's a lot of people that struggle with understanding, and I'm one of these people, understanding insurance in general. I mean, like, I don't know if you've ever tried to interpret everything that's part of your benefits, but everyone struggles with that. So that, I guess that'd be my answer in terms of important processes to put in place.
Wow, thank you so much for speaking with us today, Ben. We had a great conversation. And, it's so much around COVID and around virtual visits. And I know they can be complicated. And like you said, interpreting your insurance can be a lot. But I thank you today for speaking with us and breaking it all down for us and allowing us to able, a language we can all understand, we can relate to. So thank you so much for joining us today. And thank you.
Second section on innovations in medical care. My name is Glenn Gedgerman. I'm a radiation oncologist and an MBA student at the George Washington University School of Business. So let me start by thanking Dr. Tarabishi. He inspired and organized us to establish today's conference. And I have to say that his love of learning and enthusiasm for creativity and innovation is really infectious. He's one of the driving forces behind our great MBA program. I'd like to acknowledge my team members who were instrumental in organizing the session: Adam Sneitzer, Katie DiLorenzo, Toyis Oyemi, and Stephen Pike. Couldn't do this without you. And finally, I want to thank Tammy and the whole team at ICSB for helping us put this together. It's my honor to introduce our speaker, Dr. Michelle Donato. I've got to think about how much of her bio I should read, because if I read all of it, we won't have time for questions. Dr. Donato is chief of the Stem Cell Transplantation and Cellular Therapy Program, where she leads one of the world's largest photopheresis centers at the John Thor Cancer Center in Hackensack, New Jersey.
I don't know what even this topic was, to be honest.
So sorry, everyone. I'm so sorry.
I want one more so in there.
So sorry.
She received her medical degree from McGill University. And completed her fellowship in medical oncology at MD Anderson. She has more than 20 years of clinical and research experience in stem cell transplantation and cellular immunotherapy, and she's published extensively on stem cell transplantation in prestigious journals. During the COVID crisis, Dr. Donato established the convalescent plasma studies at Hackensack University Medical Center through her own FDA-sponsored trials, and identified and administered high neutralizing titer convalescent plasma. So Dr. Donato, it's really an honor that you joined us today.
Thank you, Glenn, for having me.
Let me start. Your research in the use of convalescent plasma in COVID patients was featured on 60 Minutes. Can you explain how convalescent plasma benefits these patients?
So yes, sure. So the infection with COVID really has two parts. The first part is when the patient contracts the virus. The virus has a spike protein, which is those little spikes that we see on the image of the virus, and that attaches to a receptor on certain cells of the body, mainly the cells of the lung, the cells of adipose tissues, kidneys, and other organs. And that happens during the first week of infection. During the second week of infection, we see the end result of the virus attaching to these receptors, which is the tremendous inflammation that ensues. So that's why when we see a spike in cases, we know that hospitalization would follow, not immediately, the week after. So it really is the inflammation that makes the patient sick. So the convalescent plasma has antibodies. These antibodies block the capacity for these spike proteins to attach to the receptors that are on the lungs. So if the virus cannot attach to the cells, there will be less inflammation, and then the second phase of the disease will be prevented.
I see. Now, I note that your work received expedited FDA approval. What was it about your approach to the use of convalescent plasma that was so unique?
So we looked for what we tried to do is to handpick donors with very high levels of neutralizing titers. So we know that most patients who get COVID develop antibodies, but we certainly didn't know then, we have more information now, is certain patients have very low levels of antibodies, and some of these antibodies really don't block the virus very well. And so just having had COVID, or just having antibodies really doesn't necessarily make this person a good donor. So what we decided to do is to invite donors to be screened specifically for high quantities of the antibodies that will actually block the spike protein. And so these donors, we reached out to them online. We had hundreds and very soon thousands of people answer us back. We brought them over. And then we sent our lab to our research laboratory, which has a virology component to it. And they analyzed the plasma to make sure that it actually killed the virus. And that is, it was in high quantity. So the patients that we selected, if we diluted their plasma 1,000 times, we still found antibodies that could block the virus. These are the donors that we specifically selected as donors for patients with COVID.
That's fascinating. I'm a little confused. I mean, you're an accomplished medical oncologist. You're the chief of stem cell transplantation and cellular immunotherapy, but that's in the division of oncology. Why are you innovating treatments for COVID patients?
So if we look back at mid-March, New York and New Jersey, I think to transport it, I have to transport you back, which I'm sure you remember what happened here in mid-March. And in mid-March, I think all the doctors here at the hospital really sat in shock of what all of a sudden happened. And we had a tsunami of COVID patients, hundreds of COVID patients arrived at the hospital. Dozens were dying every single day. We watched in shock and horror. And what happened is all of a sudden the researchers from the cancer center, we all got together and we said, we're the researchers. Somehow we have to roll up our sleeves and make something happen about this. And so, so we got together, we engaged the research laboratory, and we divided tasks for everybody, who's gonna look at what, who's gonna research what. And because in transplant, we deal with cells and blood components, and we select donors for leukemia patients all the time, it was the low-hanging fruit was for me to lead that program. But that's really what happened.
I see. So it's very interesting. Dr. Tarabishi is teaching a course on creativity. So based on what you just told me, do you consider yourself a creative or an innovative person? And do you think there's a difference between those two terms?
Well, I think being creative is probably coming up with a brand new concept and a new idea. So this project would make me absolutely not creative at all, because convalescent plasma was used in 1919 during the Spanish flu. By the way, quite successfully. If you look at meta-analysis, it showed that patients, there was improvement in survival when administered within the first 4 days of symptoms. So I think maybe there was an innovative component to it, because we used something that was already been established, but we used it within the context of what can be done in 2020, which was actually using plasma as a drug. So not only are we giving plasma, we know exactly what we're giving. For example, with Regeneron, we heard that 8 grams per kilo was given to the president. Well, we give about 3.5 grams per kilo per unit of plasma. So there was some component of innovation, but I think all in all, it was teamwork and elbow grease probably more than anything else, quite frankly.
Okay, thank you. So I understand that definition of innovation. So let me shift now. Have there been recent innovations in the treatment of cancer? And what new approaches do you expect over the next 5 to 10 years?
What's happened in cancer over the last 5 years is phenomenal, incredible, and it is getting better every year. So I think there's probably two parts of treating cancer outside of anything that has to do with radiation, because I know very little about that. That's your domain. But in medical oncology, I think two things. One is what I would consider targeted therapy. So we now have a much better understanding of the molecular aberrations and of the pathways inside the tumor cells that lead to the behavior of the tumor cells. So we are creating and finding therapies that can target those individual pathways, as opposed to just blankly trying to kill cells that divide faster. That's old-fashioned chemotherapy that makes your hair fall out and gives you mouth sores. But targeted therapy, and there are more and more of these agents now that can target specific cancers. So when we see, for example, leukemia, we do molecular tests of about 1,000 different potential aberration, and we have targets or agents for some of those targets. So the expansion of these agents, I think, is the next big thing. Secondly, that's the first part. Secondly is immune modulation. And so we can now harness the immune system to fight the cancer. For example, in chimeric antigen receptor therapy, the CAR T therapy, we take immune cells from patients, we genetically engineer them so that they can grow, for example, a flagpole that will have a receptor to attach to the tumor. And it really is thanks to development in virology. So when we studied the HIV virus, what the HIV virus does is that it invades the cells, it attaches to the cells, it delivers into the cell a piece of DNA and the equipment for the DNA to become something. So we use the knowledge that we gained from the HIV virus to say, well, we can deliver a piece of DNA that we like into an immune cells using the capsid of the HIV virus. And then the DNA will go into the immune cell. The DNA is a blueprint. So the immune cells will grow a new receptor. And that's a receptor that targets that patient's specific cancer. So it is now prime time, that technology. We treat patients almost every day with CAR T therapy, and these constructs are getting better. And so we can now have 2 receptors, 3 receptors, and so on. So I think that's the second part of the new big wave in terms of cancer treatment.
Fascinating. Well, Dr. Donato, I'd like to thank you and your team on behalf of all individuals, family members that have been touched by COVID or cancer. I think it's physicians like you, researchers like you, that have the dedication, the innovation, and the compassion that really give us a lot of hope. So thank you for all the work that you do, and thank you for sharing your innovative ideas with us.
Glenn, wonderful, wonderful comments. Dr. Donato here, which is amazing here. I want to ask you a question here. The work that you're doing and what's happening here, I want you to talk a little bit about the balance between men and women and work. There's research that comes out saying that women are having a harder time during COVID-19 because of the balance of work and life and family. What's your reaction to this? As you are leading us in this, you also have to understand that you also are dealing with unfair ways COVID is affecting both men and women. What's your reaction to this?
I think there's two parts to the question in terms of how has COVID impacted us as a society. Certainly in terms of people who are impacted by the virus, men disproportionately are getting sick and are getting sicker. So in our study, about 65% of our patients were male, and actually about 67% of our patients were Hispanic. So male disproportionately are being affected and are getting sicker than women. Women are impacted differently. There's no question that certainly a lot of the burden in today's society of child rearing certainly is on our docket, and virtual learning and so on has certainly made that more complex. So it maybe has even exposed some of the challenges that women have already. No question that it has certainly opened our eyes a little bit more from that perspective.
Thank you very much. This is exceptional. Thank you.